Hey kids! So welcome to chapter 54, and this chapter is about nursing care of patients with integumentary disorders. So we're going to go through the pathophys of the skin disorders that are listed in the chapter that I will talk about the etiologies, the signs, and the symptoms of these disorders, what therapeutic measures would be used for those disorders. We're going to talk about data collection, subjective, objective data collection, so that we can recognize what kinds of integumentary disorders they have. What is your role as the nurse, especially with the prevention of pressure ulcers? How we plan nursing care, and how we know that if the things that we've done, our interventions, have been effective. Okay? All right, so we're going to start off with pressure ulcers. Pressure injuries, pressure ulcers, decubitus ulcers, they all mean the same thing. It is a erosion of the skin and tissue at bony prominences that's caused by pressure, okay? And when there's pressure against the skin, it results in necrosis or death of the tissue, okay? So it's called tissue anoxia. No oxygenated blood to the tissue equals necrosis. And it's pressure, it's caused usually by immobility. It's the most common reason. So as far as risk factors, immobility, right? Immobility is the #1 risk factor. Impaired circulation also plays a role. Impaired sensory perception. So in other words, if the patient's sensation is diminished, they may have an issue that they're not feeling, and then before you know it, it doesn't take very long for skin to break down. Of course, the elderly are always more fragile, and people that are very, very thin, they are absolutely a higher risk, those bony cachectic people, and the word cachectic means skeleton-like. Obese patients, it can happen because of pressure, but that's a little bit different. And I can talk about that later, but really your dealings are going to be pressure ulcers resulting from pressure on bony prominences, secondary to immobility. How do we prevent them? Well, the first thing we have to do is how do we predict what the risk is? And then we use something called a Braden scale. And almost every facility out there, whether it's acute care, whether it is long-term care, rehab, doesn't matter. The Braden scale is a very reliable and standardized tool that's used, and it goes through different sections, and then the patient gets a score, and that will determine if they are high risk or low risk, okay? Keeping skin clean and moisturized is of paramount importance. If the patient is incontinent, remember, urine and feces are very acidic, and they will cause pressure ulcers in no time. Moisture barrier should always be used at the perineal areas for people that are incontinent. And here's the cardinal rule. It's very rare that I can say this, but never, never, never massage reddened areas, okay? Because the massaging can actually cause that to break open, and we don't want that. So prevention is the key, as it is with almost everything. Patients should be repositioned if they are unable to reposition themselves minimally every 2 hours. Bony prominences should be padded with pillows, right? Protect them. We should always use pressure reducing devices like air mattresses to prevent, injury. When we move patients, they should never be pulled in the bed. Should always use a lift sheet so they can be lifted up and moved, all right? Because that can cause something called friction and shear injuries. And nutrition, you are what you eat. And so, protein, B vitamins, all those things are important for epidermis and dermis to maintain health. And then adequate hydration, of course, is always, important. I've given you an example of the Braden scale. It goes through the different areas that are scored. So you take a look at that. So what does a pressure injury or ulcer look like? Usually, initially, they're painful. They can be an open, ulcerated area. They can be a blister. Also, it can present, especially at the sacrococcyx area, as non-blanchable hyperemia. Non-blanchable means, and I'm going to give you an example. If you look at my skin, when I push on it, it's white and then it gets nice and red again, right? If you push gently, not hard, but at the sacral area, that if you see that it's red and then you push on it, the area will not turn white. It's non-blanchable, not turning white. And the hyperemia just means that it stays red. That is telling you loud and clear, this is a stage 1 pressure sore. This is not just, it's just redness. It's a pressure sore, stage 1. The wound can appear black. If there's black areas, black is never good. That's an indication of necrosis, necrotic tissue. It's dead tissue. You can also see what's called slough, and that usually looks stringy, thick, almost like a purulent exudate, but not exactly. It's harder than that, and it's yellow. Or the wound can look red and beefy. Just envision yourself slicing open a steak. You know, that red, beefy, granulated look? Well, that's good. That's a healing wound. That is what we're looking for when we're looking at pressure ulcers. What I've done is I've taken the WOCN pressure ulcer staging guidelines and inserted them into this PowerPoint for your viewing pleasure. So what is the WOCN, you ask? Good question. Wound and Ostomy Care Nurses Association. So there are nurses that specialize simply in wounds and ostomies, and that's all they do. And that association, they're the ones that basically write the book on guidelines, what therapeutic measures we use to treat wounds, et cetera, et cetera. When you look at these guidelines, you'll see that pressure ulcers, only pressure ulcers are staged. Diabetic ulcers and venous stasis ulcers look like pressure ulcers, but they're not at bony prominences, and they are not staged, okay? Pressure ulcers would be at bony prominences. In other words, sacrococcyx area. They could be at the elbows. They could be at the iliac crest, the hips. And here's one that people don't think about. If the person's on oxygen and they have nasal cannula tubing behind their ear, always look behind the ear, because they can develop a pressure ulcer behind their ear from the tubing, from the pressure of the tubing. True. So how do we categorize them? They are 1, 2, 3, 4. Those are the stages. Stage 1 is intact. In other words, the skin has not broken open. It is an area of erythema, redness, okay? But it's usually non-blanchable, okay? And it's usually over a bony prominence. And there's an example. Stage 2 is what we call partial thickness skin loss. In other words, part of the epidermis and the dermis is lost, okay? The erosion has now opened the area, so it's through the skin. It's shallow, like a shallow wound, usually with a red or pink wound bed. It can be intact, or it can present like a serum-filled blister. Yes, a blister. And so, in other words, especially at the heels, okay? If you have a bed-bound patient and their heels are constantly on the bed, the heel can develop a blister. Well, that blister technically is a stage 2, because even though the blister itself is intact, and for the love of God, leave it intact. Years ago, we used to pop them. We now know, don't do that, because underneath now it's open, right? So that's considered a stage 2 partial thickness pressure ulcer, okay? Stage 3 is a full thickness loss. In other words, it's gone through the epidermis and the dermis and into the subcutaneous or fatty tissue. So you'll see the fatty tissue visible, but you shouldn't see bone or tendon or muscle, okay? You might see some slough. You might see what's called undermining or tunneling. And, I'm going to actually put some pictures in here as an afterthought so that you know what undermining and tunneling means. When you're assessing a wound, you get a cotton-tipped applicator, those big long Q-tips, and at the wound, so if the wound were here, you would take that cotton-tipped applicator and gently push at the edges of the wound, underneath of it, to see if it's open under the edges of it. That's undermining. And then tunneling is where if you're pushing under the wound, you can actually go underneath of it and there's a tunnel, which means the patient's going to have another wound or one really big one. And I'll include some pictures there, okay? And that needs to be documented. And then last but not least, we've got a stage 4. Stage 4, if you've never seen one, is like an anatomy lesson. Stage 4 is a full thickness loss. So we've got the epidermis gone, dermis gone, subcutaneous tissue gone. It's all the way down to the muscle, bone, ligament. Okay, I mean, I've seen some of these at the sacral area where you can see every bone, muscle. I mean, they really are like, sadly, like an anatomy lesson. And they're very difficult to heal if they're allowed to get to that point. Okay, that's a stage 4. Then we have something called unstageable. So if you look at a wound and the entire bed of the wound is covered with black necrosis, necrotic tissue, well, you don't know what's underneath it, do you? So you can't stage it. That is considered unstageable. Because if we were to debride it, and debridement means to remove dead tissue, we have no idea what we're going to find underneath that dead tissue. So therefore, a wound that is covered in either black necrotic tissue or yellow slough is considered unstageable. And then last but not least, we have something that's called suspected DTI, deep tissue injury. And usually what we see is it's either really purple or maroon, or it looks like a blood blister, right? It's usually painful, and when you touch it, it feels boggy or mushy, right? And so the reason that we consider this suspected deep tissue injury, again, if we were to try to debride that and, where that purple blistery area is and go beyond, beneath it, well, I don't know how deep it is, right? And it's really difficult to tell how far that wound is evolved underneath that purple or, bloody blister that we see. So that one is another dangerous one because you don't know what lies underneath of it. Okay. And then there's an additional picture of, how pressure ulcers progress from a stage 1, which is that non-blanchable hyperemia, stage 2, stage 3, stage 4, unstageable, and then suspected DTI. So what do? Number 1, got to get the pressure off. Okay, so the patient needs to be repositioned. Wherever there's pressure, the pressure must be relieved. Okay, debridement. Debridement is a term that means the removal of necrotic or dead areas, because if there's necrotic tissue, the wound is not going to be able to heal. Wounds heal from the bottom up. Okay, the skin, the top layer of the epidermis, is going to want to close up, but that doesn't mean that what's underneath is healed. And so it's important that dead tissue is removed so that it allows the area underneath to go ahead and become beefy and granulated and healing. And so debridement can be one of 3 ways. It can be mechanical, chemical, or surgical. So mechanical debridement is a wet to dry dressing, right? So a wet to dry dressing is where we get gauze, usually 4x4s or 2x2s, depending on the size of the wound, sterile. It's not a sterile procedure, but sterile 2x2s or 4x4s. And we soak them with normal saline, and you kind of wring them out so that they're very, very moist. And they are placed over the wound, and then on top of that, dry gauze is placed. And it's left in place usually for 24 hours. And what happens is, as it's, there's a wet environment on the wound, but over time it'll start to dry. When it's removed, gingerly, don't hurt your patient, or medicate them for pain 30 minutes before you do these types of wound care procedures. When you remove that wet to dry dressing, hopefully the gauze will pull away some of the slough. And so that would be a mechanical debridement. Chemical debridement is also known as an enzymatic debridement. And the drug of choice for that is a topical ointment called Santal. And Santal is what we call a collagenase debriding. So in other words, it's got an enzyme in it. When it meets dead tissue, and only dead tissue, not good tissue. So Santal, when it meets the dead tissue, an enzymatic action occurs where it kind of eats away at the dead tissue and therefore promotes healing. Santal will not damage good skin or tissue. That is a common misconception, okay? All they have to do is read the insert to the Santal. And last but not least, we have surgical debridement, and it's just what the name implies. So the patient's going to go in either to an outpatient surgery center. Sometimes podiatrists will do this in their office. They have like a little surgery suite. And they will surgically, with a scalpel, cut out the dead tissue. Usually we wind up with a size bigger wound, right? But it's going to allow the wound to heal. surgical debridement is not recommended for diabetics, okay, for obvious reasons, because of their issues with non-healing and with circulation and the fact that they're now going to have a bigger wound and it's going to take longer to heal. Enzymatic or mechanical you would use if they're diabetic. All pressure ulcers require a moist wound environment to heal, okay? So what kinds of things do we use? Hydrogel. Hydrogel is a clear gel, and it's a water-based gel that's placed on the wound bed with a dressing on top. Hydrocolloid wafers, in other words, things like Duoderm. And if you've never seen a Duoderm is usually like a tan-colored wafer-looking dressing that's self-adhesive. You pull off the backing and it sticks on. And it's kind of thick, so it's got a little padding to it. And it's a water-based embedded into the dressing so that it keeps the wound moist, keeps it and allows it to heal. You have alginates. You can have silver or calcium alginate dressings, which means that the dressing itself, and these are expensive, by the way, but they are embedded with either silver, silver, just like jewelry is silver, right? Because silver has antibacterial properties and it helps to prevent wound infections. So it can be embedded with silver or it can be embedded with calcium, which a calcium alginate actually does help promote wound healing. And then, of course, you've got your wet to dry gauze dressings, which we've talked about already. For really significant wounds that are difficult to heal, we have something called the wound vac. The wound vac is negative pressure wound therapy. So what it is there's a machine, and it's got a tube that goes to a very specific transparent dressing with a sponge that is placed over top of the wound with that transparent dressing over it. And when the pump is turned on, you're going to see numbers start to go down. So initially you turn the pump on, you hear, and then it'll get quiet. You might hear, I've worked with these for a long time. What you're looking for is silence. Because if you're hearing, or that means there's an air leak. So that means that that dressing on the wound is not airtight. You need an airtight seal because that pump is drawing on the wound negative pressure to bring oxygenated blood to it to help it heal. Okay? And typically the protocol for wound vacs is the dressing is changed every 72 hours, and that's whether they're home, hospital, it doesn't matter. And it's usually negative 125 millimeters of mercury that you're looking for on the screen. So that is a wound vac. And then nursing diagnoses that go along with this: impaired skin integrity, risk for infection, and pain. Right. Next, this is going to be quick: dermatitis. Dermatitis just means inflammation of the skin. That's what it means. So in other words, you go into the ER, you've got this rash, the doctor looks at it, and in his mind he goes, dermatitis. Okay, so it can be an allergy, it can be an irritant chemical, it can be hereditary, it can be stress, it can be anything. So dermatitis is really a very vague kind of diagnosis. Contact dermatitis, maybe you used a new soap or a new lotion or something that your skin did not like and it reacted. Poison ivy causes a contact dermatitis. You can have atopic dermatitis, which is more oozy than itchy, but it's chronic and it's usually inherited. And then you can have seborrheic dermatitis, which is also chronic. So atopic and seborrheic thought to be autoimmune, possibly, but the most frequent one that is seen is contact dermatitis that's usually caused by some kind of an irritant to the skin. And there are a few pictures in that little slideshow, okay? So signs and symptoms are, rash and itching. They can be scaly, they can be crusty, they can be fissures, cracks in the skin, they can be macules or papules or pustules. And, complications, if it's not treated, can certainly include infection and sepsis or septicemia if the infection is not identified and treated. So what do we do to diagnose? Well, history and physical, and one of the big ones is allergy testing, or eliminate the allergens. So if I start asking you, have you used anything new lately? And you say, well, I stayed at a hotel, and after I slept in the bed is when the rash started. Well, it's probably whatever detergent the hotel used. And so you eliminate the irritant. Typically, you will eliminate the dermatitis. Okay? And we can use things like antihistamines diphenhydramine like Benadryl. We can use analgesics if they're painful. We can use antipyretics, which are anti-itch medications. Calamine lotion is one. And then there's also a topical diphenhydramine. And if it's really bad, we can use steroids. That's usually the last effort. And then one of the most holistic and useful kinds of treatments are oatmeal baths. Okay, they really do work. All right, next is psoriasis. Psoriasis is also believed to be autoimmune, and it's an inflammatory disorder of the skin where the proliferation of the epidermal cells, the cells grow really fast, and they're itchy, and they're really dry and scaly and flaky. Okay, so this is really believed to be autoimmune. We really don't know. So I'm going to go back to that word idiopathic, which means aggravating factors. People with psoriasis, one of the number one reasons that they'll have an outbreak, stress, something stressful going on. Also streptococcal infections can be a precipitating event. Hormonal changes, weather can be a precipitating factor. Trauma to the skin and certain drugs can actually cause psoriasis. Believe it or not, hydroxychloroquine. Hey, Trump, got any skin problems? Anyway, back to this. Signs and symptoms. There's a really good picture on this slide. It's almost looks like a snake skin where it's flaky, silvery, plaque, itchy. Okay, very annoying for anybody that's ever had it. And it can lead to infection if it's not treated or if it's persistent. It can also be something called psoriatic arthritis, where it can actually kind of inflame the joints. And then there's sometimes is lymphadenopathy, so swollen lymph nodes or nodules close to wherever the outbreak is. So, and we're going to look at your white blood cell count, physical assessment. Treatments are going to be, again, those oatmeal baths work wonders for anything that's itchy. Corticosteroids topically. Corticosteroids and immunosuppressants orally if it's a really severe case. And we can use things like cyclosporine, Sandimmune, which you should know, and methylprednisone or methylprednisolone, which is a steroid. Over-the-counter remedies are coal tar. So if you've ever seen any of the over-the-counter remedies for this, they usually are this thick black, and they really are made of coal tar. And then, and make sure you know this, it's a board question, psoriasis, one of the treatments, ultraviolet light, right? That's not why I tan, but it works anyway. So that is psoriasis. Next, we're going to go to the herpes. So first we have herpes simplex. Herpes simplex are viral infections, okay? And really there's type 1, type 2, and believe it or not, varicella and zoster is type 3. So one at a time. Herpes simplex type 1, the most common one. The cold sore, fever blister, whatever you call it. It's usually something up here, but it usually presents itself as a cold sore. Herpes simplex 2, it's the gift that keeps on giving, if you know what I mean, okay? That's the genital herpes. And it is transmitted via direct contact. And I want to make this abundantly clear. People that have genital herpes do not have to have an outbreak in order for them to transmit it to another person. In other words, you should never have unprotected sex. Condom, okay? Because if someone is forthright and says, hey, I got the herpes, but ain't nothing happening right now, you can still get it. You must use a condom, okay? If you don't remember anything, remember that, because you don't want the gift that keeps on giving. And what happens with all the herpes is they have this little trick that they can go to sleep inside you. They can lie dormant, and then usually stress is a trigger. They can rear their ugly head again. It holds true for cold sores. It holds true for the gift that keeps on giving, the genital herpes. And we're going to see it holds true with varicella, chickenpox, in its reemergence as shingles or herpes zoster, later on down the line. So, I mean, and basically it's a burning, tingling, and itching all at the same time, if that makes sense. If somebody has an outbreak, and this is an ATI question, and it's a little useful piece of information. With the genital herpes, it hurts to urinate for women if they have an outbreak. So one of the tricks that we use is we give them, you know, when you had a baby and they gave you the squirt bottle with water in it and you could squirt around your vajayjay, right? Well, when someone has an outbreak of genital herpes, when they must urinate because urine is acidic, and when it hits the herpes, it'll burn, you instruct them to use a squirt bottle and squirt water over that perineal area while they're urinating so that the herpes don't burn, okay? Don't forget it. All right. And what do we use to treat it? Acyclovir, which is an antiviral. It can be oral, it can be topical. Sometimes if it gets real severe, we can give antibiotics if there's a secondary or superinfection. But the biggest thing is prevention, so avoid whatever the trigger is. If the trigger is stress, manage stress, okay? All right, next, the herpes zoster. So herpes zoster, shingles, is the varicella zoster virus. In other words, if you've had the chicken pox as a child, that virus will lie dormant, asleep inside of you. And later on, and we're not exactly sure why, because some people get it and some people don't, it rears its ugly head. But this time it's different. So chickenpox, varicella, when the virus starts, and remember, varicella is airborne, right? So you catch the chickenpox, it starts out a little malaise, maybe a low-grade temp, redness, a little itchiness, and then the next thing you know, you've got these pox, right? You've got these macules, vesicles all over your body, not on the soles of your feet or the palms of your hands. They're the only two places that you won't get them. But it's generalized, it's everywhere. And they will itch, but they will run their course because remember, viruses are self-limiting, okay? They can only last for so long. And so you'll feel cruddy for a while, and then they will start to dry up and itchy even more when they're drying and crusting, and then they'll go away. But years later, when you're older, for some people, stress is a trigger. They will rear their ugly head again, only this time as herpes zoster or the shingles. They are painful because they actually run on a nerve root. So they're not superficial like the chickenpox. The chickenpox are on the skin. Herpes zoster is attached to a nerve root. And the two most common are around the side, which you can see in the top picture, and then the other one that's nasty. At the cervical spine, it starts here, and it goes up on one side of the head and face, which means it can affect your vision and your hearing because it's on a nerve. It's deep, okay? And it's unilateral. In other words, it's one side of your body, okay? Make sure you know that. And I went to the Merck manual and I pulled information out about it and you know how it's attached to the root base of the nerve. That's why it's painful. We see it in older people. We see it really frequently in people with HIV and frequently in people that are immunocompromised for whatever reason. But there are no, and I underlined this and italicized it and bolded it, there's not a clear-cut precipitant. In other words, I had the chickenpox when I was a kid. And, you know, I'm pushing 60 and I've not had the shingles. But some people get them, others don't. So we really don't know why. Okay. And prevention, well, I mean, avoidance of infected persons, of course, manage your stress. And for people over 60 that are at risk, they are recommended to get the Zostavax vaccine. Okay. And the other thing that I want to talk about real quick is post-herpetic neuralgia. In other words, after herpetic herpes. After the herpes, you got nerve pain, neuralgia. Wherever you had the shingles, that area will be tender and painful forever. Forever. There are lots of different treatments that have been used because it's a nerve pain, it's a deep pain, and things like Lyrica or gabapentin, Neurontin, are used, sometimes with help and sometimes not. So, you know, the area where the shingles was, you know, try to keep any irritants away from it. And I'm talking about even after the shingles have healed and gone away, okay, because it will hurt forever. When a virus presents, so like chickenpox or shingles, we can give acyclovir and we can give it right away. So you want to try to give it within 2 days or so of the outbreak, because it can't cure it, but it will lessen the symptoms and quicken the disease process. It won't cure it, but it helps. But it's got to be given right away. Okay, and then we can give things like antihistamines for the itching and analgesics for the pain, et cetera, et cetera. Okay. Fungal infections. There's a fungus among us. You got to know about these, because I know that the Board of Nursing does like to ask about maybe one of them, but you never know which one. So when you see tinea, a tinea is a fungus, okay? But there are different types of tinea. You've got tinea pedis, athlete's foot, like pedal pulse, pedis, right? Tinea capitis, it's cradle cap in infants. Tinea corporis, that's ringworm. It's not a worm at all. It's a fungus among us. Tinea cruris, it's the jock itch. And then, of course, last but never least, you've got the candidiasis, which is the thrush. You could get it orally, or you could be baking bread downstairs. All kidding aside, and it actually is quite annoying, candidiasis. So make sure you understand tinea pedis, athlete's foot, tinea capitis, cradle cap, tinea corporis, ringworm, and tinea cruris, I got the jock itch. And last but not least, candidiasis. Okay. What do we do? You know, the biggest thing you can do is to keep your patient's skin clean and dry, because fungi love a dark, warm, and moist environment. That's where they love to grow. And so you will see sometimes, and this always breaks my heart, if you see a heavy lady, maybe in a nursing home, long-term care facility, that's a large-breasted lady, you know, sometimes under the breasts, you will see these nasty fungal infections, because you got to get up under there and keep it dry, okay? And what do we use to treat it? We can use topical antifungals. We can use oral antifungals, sometimes corticosteroids if the symptoms are bad and they're painful, okay? And prevention is always worth a pound of cure. Next, we've got cellulitis. Cellulitis just means an inflammation of skin and the connective tissue under it. Most common is a MRSA-based cellulitis, in other words, Staphylococcus or methicillin-resistant staph, and then Streptococcus. So it's usually bacterial, okay? Open wound or trauma can be the etiology. One of the more common etiologies, too, people with chronic edema of the lower extremities. Your skin will only stretch but so far. So when the skin is tight, taut, because it's edematous and stretched out, at some point, it's going to be like a dam, and it might have an open area, and you'll see this thin, clear fluid leaking out. That patient's going to wind up with cellulitis in the lower extremities. Common, very, very common. What you'll see is you'll see redness, you'll see warmth. The edema may have been there before or may come afterwards. It's painful, it's tender. And if it progresses, the patient can have a fever or lymphadenopathy, in other words, those swollen lymph nodes. We can do CNS, culture and sensitivity, to figure out what kind of bacterial infection it is and then treat appropriately. We can do blood cultures if it's become systemic. And again, you know, if it's caused because of edema, treat the cause and then treat it. If the wound that has become inflamed or infected needs to be debrided, sometimes that's a cause where there's so much necrosis or slough, the wound won't heal and it starts to turn really, really red and angry looking. Cellulitis, okay? Debride it so the wound can heal, okay? All right. Next, pediculosis, which sounds so cute, but it's lice, right? And this is also something transmitted by contact. So pediculosis capitis, head lice, pediculosis corporis, body lice, and pediculosis pubis is pubic lice. Just understand that lice is transmitted contact. And the most common time you'll see it is in schools with kids, because kids are really bad about social distancing, right? And they will touch each other constantly. And don't be fooled. People say, oh, you know, it's because you have a dirty head. No. Actually, lice like a clean head, okay? And if you use a lot of product on your hair, you're probably not going to catch it. Not definitely, but there's a very good possibility you could be safe because the product, they don't like gels and sprays and all that stuff, okay? You'll have symptoms that are itching. You see somebody scratching their head, scratching, scratching, scratching. Sometimes a rash. And you will see sometimes the lice, but the other thing you'll see is the nits. The nits are the lice eggs. And it looks kind of like dandruff. They're little white specks in the hair. And they make a special comb, a nit comb, that with treatment, you put the treatment on the head and you can comb the hair out and it combs the nits out. Understand that with interventions, there's something called permethrin. It's over the counter. It's called RID, over the counter. That's the most common thing used. In order to get rid of lice, everything has to be washed in as hot water as can be tolerated and dried in the dryer, heat, okay? If the patient is a child and they have things like stuffed animals, those kinds of things, they have to be put into an airtight bag if they absolutely can't be washed. An airtight bag in the dark, in that airtight bag, usually for about a week, okay? And then if one person in the family has them, probably everybody's got them too. So it's important to inspect the whole family. And then last but not least, the scabies. Here's the thing with scabies. Scabies is also kind of a parasite. Well, not kind of, it is a parasite. But they are tiny little parasitic creatures that will burrow under the skin. They are transmitted through contact as well. You will see these in nursing homes. And when one resident gets them, everybody's got them. And again, you'll itching, rash. But here's the thing with scabies. Trails. And I'm actually going to put a picture in here. Trails, you will see a line, a rash that looks like a line. Okay, that's one of the cardinal hallmarks of scabies. It's the burrowing line. And then what do? Well, again, it's almost the same thing as with the treatment for lice. It's the permethrin, which is a topical scabicide, something for the itching. And then again, you got to treat everything. You got to wash everything. The bed linens, the towels, all the clothing. Get rid of the pillows. Get new pillows. Unless if the pillows can be washed, wash them. If they cannot, they have to be replaced. And those patients can itch for like 2 weeks after the treatment has been implemented. Now we have cancer, malignant skin lesions that we're going to talk about. Well, now the big C, malignancies, malignant skin lesions, in other words, skin cancers. So there are 3 types of skin cancers. You've got basal cell carcinoma, squamous cell carcinoma, and malignant melanoma, which is the bad one. That's the really bad one. It's the fastest growing and it can metastasize everywhere, okay? That's the one that'll kill you. What basal cell carcinoma looks like, there's a pretty good representation there on slide 58. Usually pretty obvious. With all skin cancers, there are some commonalities. A mole that changes size or shape, usually raised, ridges, irregularly shaped, like they're never round. They're usually kind of squiggly squaggly. But a basal cell carcinoma is a slow-growing cancer of the skin that can be removed or frozen off by a dermatologist with a very good prognosis. Squamous cell carcinoma is a little nastier because it's a little deeper. It goes to the dermis. But again, it can look like this weird, rashy, crusty, irregularly shaped, funky colored lesion, right? And then malignant melanoma, I mean, that's a pretty extreme case. And if that's between the toes, that picture, that's on slide 60. And you can see it's basically eating away at the tissue, okay? Don't worry about the specifics of the lentigo melanoma. Risk factors, and I'm going to tell you that ultraviolet light, which is light from the sun, is definitely a risk factor. But the biggest thing is fair-skinned people and sunburn. And I'm going to put that in there with lots of stars after it. If you've ever had a blistering sunburn, not just any old sunburn, a blistering sunburn, you automatically are an exponential higher risk of developing a malignancy on the skin. than darker skinned people or people who have never burned, okay? And then it runs in families. Cancers tend to run in families. Genetics, you can't change. And, things like X-ray therapies or radiation therapy, which can cause blistering burns to the skin, can be a precursor to a malignancy down the road, okay? So that's important to know. What do we do about them? Well, don't get a sunburn. Use sunscreen, wear protective clothing, and then again, remember, any change in a lesion or a mole or a freckle, whatever you want to call it, where it changes size or shape or it's become raised or it's got ridges now, it looks different, or something new has popped up. And these cancers, especially the malignant melanomas, they'll be pretty colored. Sometimes they'll have blues and purples in them. And just immediately, the quicker you find it and become diagnosed and treated, the better the prognosis is. End of story, always. And that's with any disease, but especially with cancer. And the dermatologist will typically biopsy it and send it out to pathology to find out what kind of cancer is it, so that we know how to treat. But it's going to get removed, I can tell you that. It's very, very good prognosis if it's found early. All right. That is it for this chapter. That was only a 45-minute lecture. There are some review questions at the end. If there's anything that you don't understand or you need clarification of, you know how to get me. Okay? All right. Until the next one, ta-ta for now. Bye.